to cover some of those areas. We're going to be working a lot closer to co-produce a lot of the work we do. A lot of the work we do is led by both experts by experience and our experts by profession. So we have a clinical group and we have a lived experience group. So everything we do is co-produced with them. So we're going to focus a lot more on working closer on their projects with them. Our third priority is campaigning and influencing changes in national policy. Sorry, I don't know what's wrong with my throat. Maybe it's just late. So I know we're going to talk about policy a little bit later, but yeah, we're focusing around kind of responding to consultations with government and really trying to put our stamp and our voices heard in some of the new policy things that are happening. And last one, just supporting our members a lot more and partnering with them in a lot of the work we do, sharing ideas. And this is where a lot of our webinars, for example, come in. So we're looking at kind of healthy weight management, for example, or cancer screenings. So we work closely with our members around developing kind of projects around that. We have a couple of webinars due. We've got our first one at the end of this month with Race Equality Foundation, and that's on physical health checks and barriers to racialized communities on accessing them. So that's at the end of this month. And I'm actually now, so I actually work with the Centre for Mental Health, who host Equally Well UK, and I work 3 days. I work on the Children and Young People's Mental Health Coalition for the 2 days, but I'm now being moved from that project to a different project, which will hopefully will have more synergy with Equally Well. So I'm going to be working with like local authorities a lot more, so leaders in local authorities, and what we call ICBs, so the integrated care boards. So they're kind of 42 areas around the UK that specialise in NHS plans and delivering better healthcare. So we're doing a lot of work around that as well. And my new role kind of combines a lot of that work. So it's really good to be bringing that into Equally Well as well. There's a couple of proposals that we're working on, funded projects with Royal College of Psychiatrists, which I can tell you about later because we're still just in development with those, so I don't want to jinx anything. But they're quite exciting prospects there as well. We work closely with them. They are members of our clinical group, and they inform a lot of the work we do. So we have clinicians talking about kind of the work they're doing as well. So that's a bit of an overview. One more thing, actually. We've just received funding. Do you remember Ben Perry? He did present at the match back in June. He put a funding proposal to the NIHR, and he's been approved for funding, which we'll get involved with some of that as well to develop. He's worked with David Shires, who some of you may know, and he's developed this risk calculator. So he's he's got some more funding to refine the risk calculator. I think it's aimed at a wider age range because I think it's people below 40 don't really, you can't use a risk calculator with them, but he's going to refine it so we can cover a large age range. So that's great news. And that's where we're at. I think we kind of hit the ground running in September. August was very quiet, everyone's away. So we've got a lot of plans. Oh, and the last one, sorry, just to update you, is the Expert by Experience group. Used to be facilitated by Rethink. Rethink used to manage them, but we're bringing them in-house to the Centre for Mental Health now as well. So we'll have a lot more autonomy over kind of what we do with them as well. So we're looking at changing our structure a little bit to see what works best. But that's a big, sorry if any of that's not clear, but
that's fantastic, Shazana. You're doing so much, and hopefully you all heard. And just to make a note that the session's being recorded, we will take some, very bad sharing for me, we'll take some notes from this and we'll distribute the notes to all the participants and those who are not able to make it. But it's really an informal collaborative learning meeting. The other thing I'd ask, and we'll keep a record of this, if you have any events or anything upcoming or any documents that might be helpful, just post them in the chat. And then we'll collate them and send them out with the notes as well, with all the links, etc. So it is an opportunity for us to sort of be across any new developments, etc. And for those who are new, and correct me if I'm wrong here, Shazana and Hannah, Equally Well in the UK is based at the Centre for Mental Health, which is a non-government, government-supported, but non-government organisation. As is Rethink and Mind. There's a lot of big advocacy organisations in the UK. And Equally Well in the UK, I believe, mostly runs on a subscription basis. So users a
Sorry, I
collective...
should have explained that. I'm just assuming.
No. Well, there's some quite a few new people here. So, and it runs on a subscription basis with a collective impact approach with members.
We're a membership organisation, so a lot of NHS trusts sign up to us, for example, charities sign up to us. So they pay us an annual fee, and that's how we're funded, basically. Or the Centre for Mental Health host the campaign, so they put funding towards it as well. And then a lot of the work we do is funded, so we go out and find funded pieces of work.
And you recently, maybe 3 months ago, launched your new strategy, which if you could actually put a link to that in the chat, that would be really great. A couple other things that are happening in the UK as well, and thank you for the introduction. Ed Beveridge, who's chairing the College of Psychiatrists in the UK, the Royal College, they have a section on physical health, and Ed Beveridge is leading that. And he is in the process and has some funding to develop a position statement on the physical health of people living with serious mental illness. And I understand that the timeline for that is about 12 months. So it's fantastic that the college are revisiting that and getting up a position statement with their new chair.
Yeah, we've just finished the proposal on that. So we are looking at finding some potential kind of leads on that as well. So yeah.
Awesome. The other thing that's happening is that the Lancet Commission paper, those who might remember in 2019, there was a blueprint for action for people living with serious mental illness. There's a subsequent round of papers coming out of that, which are due out in February. One which is focusing on lifestyle, another one which is focusing on medication, another one on public health approaches to the improving the physical health of people. So yeah, I understand that all 3 papers have been going for a while, are due out in February. So it's follow up from the Lancet Commission blueprint. And exciting, well, there's all sorts of links there, but also Nancy Liu, who did the World Health Organization paper on the multi-level framework, she's writing one of those. So one of the papers is combining the WHO multi-level framework with the Lancet Commission blueprint around physical health and mental illness. So we're hoping there'll be helpful updates and advancements in that area. Okay. Thank you, Shazana. Great, great model for everyone to follow. Hannah, did you have anything to add?
Kind of think Shazana kind of like covered it all. So I can't think of anything.
In addition to that, Hannah, because there's a couple of those pieces that we've only just been told about, like yesterday and today. So
yeah, no, I realised that, and yeah.
Well, that's fantastic.
Yeah. I don't think I have anything to add.
Oh no, well, thanks,
Thank
Shazana.
you, though.
And it's great that you're getting involved with Ed Beveridge as well. Forgot to include that bit, and that's a good piece of work that we're really excited about, because it's going to be quite high end, not higher level. It's going to target, it's going to make evidence-based recommendations, what government should be doing, what NHS should be doing, and then taking actions forward. So it's quite a big piece of work.
And sort of in my language, that's sort of getting into the authorizing environment. When you get a piece of work from a body like that, then you can use that as leverage with other agencies who should be taking this more seriously. So yeah, those pieces of work are really quite, pivotal. Okay, I'll throw it open to someone else who wants to share what's happening from your country at the moment.
I'm happy to, Russell.
Thanks, Emma.
Oh, sorry. So, actually, just listening to that, talking about Equally Well UK being 5 years. So I think we're on 10 years this year in New Zealand. I suppose probably interesting context that we've got, which I know not all of it will be unique to us, but we've got a pretty dynamic and fluid health environment in New Zealand at the moment, with a lot of reforms and some interesting political climate here. So Te Pou we're a workforce development agency that is government funded. So we've had the role, we've been able to provide that backbone function for Equally Well in New Zealand for really since the outset. The last couple of years, we haven't been able to draw on our government funding for that in terms of, so unfortunately our board has continued to support that, which just means that we've had to be really targeted about what we do, just because we're a bit more limited in terms of the resources available to us. Probably the two key things that are happening at the moment. So I think at the match, for those there, my colleague Helen Lockett, who probably lots of you will know, has been the biggest champion you could ever come across around Equally Well in New Zealand, presented around some of the work that's been happening in New Zealand. So really fortunate to have some incredible recent research that was just published last year and early this year. So for us, a key focus is on continuing to disseminate the outcomes of that research and promote the findings to look at what we need to do. And a really key focus of that is the impact of diagnostic overshadowing and the role that has for people with mental health and addiction issues and and how they can therefore access health services. So we've got Michaela's in the process of organising some workshops over the next few months to look at how we promote and share that information and get champions involved in identifying what they might want to do in terms of addressing that. We also have the opportunity through some of our workforce development work to also then look at what might be a workforce initiative that will help raise the profile of addressing that inequity from a workforce perspective. So yet to know what that might look like, but hopefully one of the things we will learn through those workshops is what would be useful from a workforce perspective. Otago University have developed a great little video, some of you might have seen, around for people that are with mental health and addiction issues accessing services, just to promote and help understand the issue of diagnostic overshadowing and how to make sure their needs are met through that. Great little video. If you hadn't seen it, we can put it in the chat if people haven't seen it. So our focus then will be on from a workforce perspective. The other thing that we're involved in that has been a really long, slow burn through some of our other work. So because we have a role around quite a range of different workforce initiatives. In mental health and addiction services in New Zealand, our largest workforce is community support workers. And so we have been advocating for the development of a qualification that has a focus on addressing physical health equity. So essentially the intent of Equally Well, but having a qualification around that designed for people working in support work roles. We've managed to get a new qualification on what's the New Zealand qualifications framework, and we're now working with a provider to develop a program on that. It's been really slow getting the education system moving at a pace we would like. The two don't quite line up, but it is happening. So we're fingers and everything crossed that maybe next year there'll be a new program available that would actually lead to, so if support workers went through that qualification, it's what we call a micro-credential. So it's like a mini qualification, would raise the profile around what support workers' role is around, essentially around Equally Well. We're just not calling it Equally Well. So that's quite exciting. Probably that work's been going on for probably 3-4 years. In amongst, because of course we've also had a whole lot of education reforms, which didn't help keeping the process moving at our end. And now our new government is reforming that again. So yeah, lots of turmoil that we're sort of navigating. So there's other things going on, but those are probably, I suppose I'd pick out the two kind of key things. Unless Michaela, you want to add anything to that, and I'm sure Manisha will have own thoughts from your end, Manisha. But yeah.
Yeah, thanks, Emma. I think sorry, I think that's a good description of it. One thing I would say for the workshops that we're developing that Emma spoke about, we've just got a name for those, which our Māori advisor Tui Taurua, who's on the Backbone team, has given us for those workshops. So it's korure e te tai, which basically means the changing of the tide. And we sort of felt as a Backbone team that really captured what we were trying to do with those workshops, which is to kind of encourage our participants to talk about actions that they can take within their own sort of workplaces and in their own sort of experiences. And we do have a few links and things, but I'll just need to gather them up. So I'll send those over to disseminate with the notes. Kia ora, thank you.
Thanks, Michaela, and thanks, Manisha, as well for keeping things going. My connection's a bit dodgy at the moment, so if that disappears, I'll ask someone to jump in and share. But yeah, thanks. And I noticed Manisha and Michaela have jumped in with some links as well, so that's fantastic. And Simon Kozak presented at our last conference at the end of May, and it was absolutely fantastic. And I think, Manisha, is that the Vimeo that you've shared, the that campaign about the overcoming diagnostic overshadowing? It's if it is, I'd really encourage you to sort of open it and have a look at it. It's really quite powerful, and it's a great example as well of people from other sectors jumping in and wanting to help. Simon is from the, I don't know what you call it, but advertising, public relations background, and is giving his time pro bono to the Equally Well team in New Zealand. But the contribution is just magnificent. So it's bringing in those diverse skills that you guys are just brilliant at. And despite all the challenges of your changes of government in New Zealand, you guys are just powering still. It's just amazing what you're doing. So yeah, that's fantastic. And I think for me, the lesson is that perseverance, isn't it? Like you're saying, how long it's taking with the education. And I think that's a great lesson we've learned too, is sometimes you've just got to hang in there for years before we get changes to some of these systems that have a lot of inertia, unfortunately. But thank you so much for sharing, Emma and Michaela and Manisha. It's great to see you all.
Yeah, thank you. And actually, I got reminded recently it takes 7 years to see something change. So,
yes.
Yeah, so we just need to remind ourselves of that, because I always get very impatient.
Well, when we started Equal in Australia, Peggy Brown, I think at the time, was saying it's 2 years to get started and 10 years to get embedded. So that's the schedule we're running on. So, and it's very wise. Someone else.
So I can go next. I'm Manaza. I'm actually representing Dr. Vicky Sturgiopoulos. And we are really in the first 2 years that Russell was just talking about. We are like really trying to figure out where we are, what is the situation. So our team basically got a grant to understand how can we strengthen, and it was a policy grant, to strengthen the integrated care delivery in SMI setting, or in the settings of the mental health in the community, and also at the hospitals as well. We have a very good a team that actually has a lot of expertise that basically is in healthcare utilization, and we have psychiatrists, clinicians, and we have like a very well-rounded team that basically is taking part in this project with us. So what we actually started doing with this was like we began with an environmental scan and a comparative policy analysis and a comprehensive literature review, and that basically helped us understand the landscape and challenges for integrated care delivery for SMI, people with SMI. And these findings informed a series of qualitative interviews. So we basically spoke to a lot of key stakeholders, including clinicians, health administrators, patients, and family members. Approximately 65 interviews in total that we actually did, interviews in the focus groups. And based on the insights gathered, we are now in the process of developing preliminary policy options and recommendations. So a little background on integrated care in Canada. And when I'm saying Canada, basically, I have very limited knowledge. I can basically tell you that much, but what we were working with is like we basically did the environmental scan of like what exactly has been going on in Canada and how we actually compare to the world. And we are really not even close to what all of you actually have achieved or are working towards. So we are really trying to get there. And we don't actually have any large-scale government initiative specifically targeting integrated care in mental health settings, but our Mental Health Commission of Canada has highlighted several potential solutions, and these include integrating health and social services, promoting health equity, addressing comorbidities in individuals with SMI as well. There's a bit more interest in the policymakers as well. So our next step basically involves in refining our policy options and engaging other stakeholders, and we are actually actively in the process of consultations as well to ensure the recommendations are actionable and aligned with our policy trends. So some key policy options that we are actually considering, they are strengthening the policy leadership through grassroots initiatives such as Equally Well. This would involve national advocacy and service organizations and collaborating to promote physical health among people with SMI. The other thing that is a more popular option item that we, after consultations that we have actually seen, is advancing the standards and accountability by building standards. So that is something that actually has been like talked about a lot. And reverse service integration by integrating primary care providers into mental health care settings that SMI patients receive comprehensive care. So that is where we really are at. At this point, we have submitted one manuscript for publication, and we are working on 3 more. Hopefully, things are going to work out, and we are going to be like, launching some initiative, and we are going to be working towards a policy for integrated care in Canada as well. So that is really where we are at. Thank you.
Wow, that's fantastic. Yes, I understand you've got a publication that's been accepted in Longwoods, which is a sort of a policy social issues journal in Canada. So congratulations. It's it's a long lead time, but the way you've approached it is very thoughtful and very thorough. So yes, it's such an important thing. So it's great to have that firm foundation, but really looking forward to see what the next steps are in Canada. I remember just before COVID, it might have been Sandra Coppett or maybe Ed Mantler from the Canadian Mental Health Commission saying, yes, we're going to do an Equally Well. But then COVID came and everything was put on the back burner. But I think, this is fantastic. So congratulations to you and your team, Manasa. It's so exciting to hear what's happening in Canada. And I think if you, when you're ready to share some of that, because I think a lot of other countries would really benefit from that investment on that policy analysis and the research that you've already done. So that's exactly the sort of collective impact and benefit that we can get from collaboration. So, but congratulations again, it's very exciting.
Thank you.
Jumping around in the agenda a little bit, but I do understand, everyone, that our next Equally Well match is scheduled for Canada. We're not too sure, and apparently it's going to be a beautiful place, according to Christopher Canning, for 2026, for June 2026. So mark that down in your diaries. So it'd be great to have that follow-up match somewhere at the next Global Leadership Exchange meeting. Anyone else? Got a few other countries, I think.
I can jump in, Russell, if unless anybody else wants. Yeah. So I actually kind of broke with tradition a little bit because I wasn't quite sure of the format here. I know it's very informal, but I actually have 2 slides. If people would bear with it, would that be okay?
Oh, that would be wonderful.
So I normally work on Teams, so I'll try and share, and you'll probably get all my family photos now, but we'll just have to see. There you go. Something happening now. Yeah.
Got it.
Can you see it?
Yep, that's fine.
Yeah.
Can you do presentation mode, or that's okay? But if you press
yes, now you and this is now advanced stuff now, Russell. No, sorry.
Oh,
no,
that's...
I was in. Sorry. Just give me a sec.
No, that's fine. We can see that. Okay, sorry, I was just being.
Can you? Yeah,
yeah, that's
I
fine.
can. Try and make it a little bit bigger. Is that more helpful?
Yeah, that's perfect. That's great. Thank you.
Is that okay? Yeah, sorry. I normally work in Teams, not in Zoom. So as Kira just mentioned there, so myself and Kira, we work for the Irish Health Service Executive, and more specifically, we work within the National Mental Health Policy Implementation Team. So I just thought, because we haven't been part of this network before, and I think it's really helpful to hear everybody's experiences from different perspectives in terms of the different roles we have in terms of progressing this agenda. So just kind of for context, I have those 2 slides. Promise I won't make a habit out of it, but anyway, just for this occasion. So just for context, the framework within which we kind of progress, I suppose, mental health reform more broadly speaking in Ireland is through the national 10-year policy, which we call Sharing the Vision. So we're kind of 3 to 4 years into that policy, and it's very much kind of a broad-based whole system mental health policy for the entire population. It contains 100 policy recommendations across 4 domains, from early intervention, prevention, mental health promotion, through to service delivery, both at primary care level, in specialist mental health service settings, through to, I suppose, accountability, research, evaluation, learning, etc. So in that sense, it's an evidence-based plan. It's informed by lived experience, and it kind of sits within the wider health reform agenda. So I suppose the ones that we probably all kind of at different parts of that particular journey, in terms of shift left, stay left, in terms of making sure that we focus on early intervention and prevention also when it comes to healthcare, and we make sure that services are available to people where they live, rather than they have to travel to access them. So kind of following from that, a key focus is actually around integrated service delivery, as you kind of mentioned, Manasa, in your presentation as well. And development of primary care supports is a key focus, because that fits very well in terms of that, agenda and that kind of overall kind of policy objective. So the policy itself is actually the second 10-year mental health strategy that we're implementing in Ireland. The first one was called the Vision for Change. And I suppose a key learning from the 2 strategies is that we need a clear implementation plan and roadmap to support the delivery. So for this policy, we have developed a 3-year implementation plan. We're coming to the end of the first one, so that's kind of a big piece for us at the moment, is to develop the next 3-year plan in terms of implementing the policy. There's a governance structure, which I'm not going to go through in detail, but you'll see that kind of to the left. It's just to indicate that there is a very clear structure in terms of oversight for the policy as a whole, through to the cabinet and the Irish government. So where we sit, Kira and I, is that we are supporting what we call the HSC implementation group. So that's, I suppose, the internal health service oversight group that drives forward the implementation of the policy. And a key part of that is that we have a number of kind of national work streams that is driving policy delivery. And there's one work stream around physical health, shared care, and primary care supports. And that's the work stream that I'm co-leading, and Kira is also involved in. And just to kind of end that note, is, I suppose, as an update in terms of where we're currently at with that work, is that we come to the end of the first implementation plan. And I suppose we've made good progress on a number of things, but the current kind of work is focusing around developing what we call a national framework for shared physical health care, which is really trying to look at the interface between primary care and specialist mental health services in terms of who's doing what, roles and responsibilities, processes that can, support I suppose the emphasis on people with severe and enduring mental illness would be have equal access, I suppose, that we all kind of talk about, to physical health care in primary care settings. And as part of that, we're very much kind of advocating for a standardized physical health program in primary care. So what we mean by that is that we are trying to get to a point where we see this on par with kind of other chronic disease management programs, where we want GPs to be paid to do 2 annual reviews, physical healthcare reviews of people with severe and enduring mental health illness, so they can be signposted into the other kind of public health programs they should access on par with everybody else in the society. So I'll stop there because I know I don't want to kill you with the slide flow, but I just thought it would be helpful just for you to show the governance structure and the way we approach it.
Wow, that's fantastic. And don't feel embarrassed at all. I think you actually set a new benchmark for all of us for future meetings.
Well, you put the emphasis on informal, Russell, so I just want to keep it at that. Yeah.
But informal, it does broad out and include slides. Kira, did you have anything to add to that? This is just so exciting, so magnificent.
Not really. I suppose just to say that there's a lot of goodwill, you know, around the topic in Ireland, I think, anyway, in national mental health and within the health service, you know. And the framework is developing well, thanks to the working group that we have around it. But, you know, it does take time, like Emma was saying, in relation to her area. There's lots of different competing issues in mental health, but we're very positive, you know, that we will get there and that it will make a difference. Yeah.
Really, just you are just so excited. I mean, you've got so many of the elements. You've got the authorising environment. You've got your national plan, and then you've got the governance framework and the implementation, reporting back to government. It's like there's so many elements in that just makes my public servant heart beat faster. So so congratulations. This is very exciting, and we've all got a lot to learn from one another. But and also thank you for
Absolutely.
the segue to talk to primary care, because that's a very different and I think also incredibly exciting approach that Thomas is doing in Belgium. So Thomas, are you able to give us a bit of an update of where you're at with your initiative? And I apologise, it must be close to 10 p.m. there already, or even 11.
No, no problem at all. Not much to say at the moment because I mentioned already we had elections, so we are waiting for the government to be installed in Flanders and in Belgium. And as a policy maker, I have to wait until that policy level is installed before I can make any progress. But I'm very well interested in the initiative of Ireland. It seems very, very nice, and it's. I want to get in touch to learn and to present our reform of primary care. I think it would be very interesting.
Yeah, that'll be great, Thomas. Yeah, absolutely.
There's a great, I think, overlap there. From what I understood from our meeting in London, Belgium's taking this initiative from the primary care approach, so which is just you know, a lot of us coming from the mental health approach, but from the beginning it's embedding it in primary care, which is a whole different way of thinking, and it's just really exciting to see how that unfolds. So thank you, and welcome. It's so great what you're doing there. So really excited to see how that unfolds over the next year or so. Anyone else? Otherwise, I'll jump in a little bit for Australia. Emma, sorry, did you have something?
I just wanted to add, just I suppose in terms of the comment, in terms of, sorry, got a frog in my throat. In terms of taking that approach from primary care, that in terms of some of that recent research that was we had within New Zealand, one of the things that was quite interesting in terms of the areas where the diagnostic overshadowing, which is where people's mental health and addiction issues get in the way of some of their physical health care, was occurring. I hope I've got this right without Helen here. The most was in emergency departments and primary care. So, Thomas, you know, if you're interested, we can kind of point you to that research. I know it's New Zealand-based research, but just might be helpful. One of the things in the mix, because that's one of the things we're considering in terms of how we kind of have a targeted approach in some of those areas as well, just given the findings of our research.
Okay,
so
perfect.
just an addition.
Thank you.
Russell. Yeah.
Yeah, no, thanks, Emma. If you could share that, it would be great. And I'll also share a publication we published, I think about 6 months ago, which actually said that women were much more likely to be subjected to diagnostic overshadowing than men. No surprise there, is there, that medicos don't take women's concerns seriously. So we'll share that publication as well. Brian and then Ken.
Yeah, so I'll just go real quickly that, you know, in the United States, the goal, of course, is integration of care, but our payer system and the way that things work in the United States doesn't always work in the direction of successful integration of care, so that sometimes we have individuals with serious mental illness where the best way to make sure that they're getting good physical health care is through their service providers of their mental health. So we have what are called certified community behavioral health clinics that one of their charges is to follow up to make sure the individual is getting good physical health care. Among the things that we work on within the mental health service providers, one is to try and minimize the smoking, second, decrease the alcohol, third, decrease the other substances. And I wish we could say we're successful to zero, but we're not. We've had some good success, especially with smoking and decreasing the alcohol, but alcohol continues to be the #1 problem, although along with smoking, although across the country, there are states where methamphetamine is actually more of a problem than alcohol. But that's only in a couple of states. Now, sometimes we get our leadership in terms of what the direction that we're going in comes from the federal government through our SAMHSA, the Substance Abuse Mental Health Services Administration. They've really been championing recently us doing more for maternal mental health, which is something that we really haven't paid much attention to in our work over the years. And the other that they've come out with trying to get more attention to is eating disorders. And we've often worked with eating disorders as a secondary issue related to depression, anxiety, other mental illnesses, but they're really trying to get us to look at this early with adolescents and also look at the issues across the lifespan. The last area I wanted to point out is an area that when it was mentioned earlier, difficult to make change, hang in there. Well, what happens is that every once in a while, and unfortunately it's getting more frequent, we have shootings. We just had a shooting yesterday in a school. Two young people were killed, 2 teachers were killed. And sadly, this is getting to be almost like a routine event. And so what happens is that, and this somebody else mentioned earlier, the political situation, the political environment. Our political environment means that what will happen is that you have this terrible situation that results in community trauma, and the way it is handled is that there will be attention on the mental health side to say, let's do more in terms of limiting lethal means, right? Limiting access to guns. On the non-mental health side, what you have is, this is really a mental health issue. It's not a guns issue. It's people who kill other people. It's not guns that kill other people. So in the end, what will happen is that there will be some legislation that does something on the mental health side and nothing is done on the gun side. And unfortunately, this is what is happening. It's recurring. And it's very frustrating. We see our young people being victimized, teachers being victimized. And it's unfortunate because it continues, and it seems like we are in one of those situations where we can't seem to get out of it. One of the big areas right now is in the area of what we call red flag laws. Many states now have red flag laws, and what they are is for extreme risk protection orders. So basically, you're identifying somebody with a mental illness who may be at risk of hurting themselves, hurting others, if they have access to a gun. So that's a way you can set up a protection order and keep the person away from getting a gun. It's not 100%, but it is one step forward. But again, it's narrowing in on people with mental illness when in fact, only a small amount of violence is done by people with mental illness. So with that, I think Ken and maybe then Richard will have something to say. So Ken?
Yeah, thanks, Brian.
Yeah, that's, well, very sobering stuff, Brian. And I guess the from the United States perspective, it's important to, and you guys, I think, probably are aware of this, that the psychic harm that these shootings do extends far beyond the immediate confines of the school district or the local community. It is really, really problematic, and it scars kids, living in states far, far away, and their parents and everybody else. So we are really caught in a loop that we do not seem to be able to escape. I just wanted to say that, echoing a little bit about what Brian said, and just put a point to it, that I really don't think you can have excellent mental health services if you don't have excellent primary health services overall. And the idea that we would ever have really, really good mental health services in which people with psychiatric challenges had really good health, in the absence of a really good primary health service is, that's not going to happen. So the issue is, how do you get to a really good whole person primary health service that then has the resources to support a really good community mental health capacity? And that's what we're all trying to build. In the United States, that is a really challenging thing for a lot of reasons, mostly because we don't actually think of health as a healthcare as a right, and we don't have a way to demarketize it enough to make it a universal good. So it's an ongoing challenge, and I just have to throw this out because it's part of the challenge that we face. For those of you who don't know, I was in Utrecht and I had a heart attack the day the conference was supposed to have the reception, and I was unable to attend. I ended up going to the ER instead. I really, really wanted a beer. It was really hot that day. I was really looking forward to being at that reception, and fortunately, my wife made sure that I didn't follow that little craving there. Went to the hospital, ended up staying there, and was in the hospital for 3 weeks. Ended up having a triple bypass. And the reason I mention all this is that I had really excellent care. I'm back in the United States. I wasn't allowed to fly for 6 weeks afterwards. I had to, oh, poor me, had to have an extended vacation in Europe, and actually got to go to the Olympics and stuff like that. But I'm not whining. I'll just grin and bear it. But when I recently asked for the bill, my insurance company in the United States agreed to pay for my hospitalization. I asked the Dutch University Medical Center for Utrecht what my bill was, what my total cost was. I'm going to ask somebody from the United States, Brian, Richard, either one of you.
30 to 50,000 probably.
For the United States?
More. Triple, I don't know, 3 weeks. Yeah.
So
yeah.
the total cost for the Dutch, $30,000. In the United States, it would have been in the hundreds of thousands of dollars that would have been charged. Now, that's not what I'm paying. I'm not paying anything because my insurance has covered it, but I have really good insurance. So one of the challenges we have is that we have a healthcare system that's completely upside down. And I think we only look to you guys just to follow along, and I offer all of this up as as a way to kind of inspire you all to keep doing what you're doing, and don't let what we're doing influence you in any way. The last thing that I'll say is that we have done a recent study here in Pittsburgh that is of interest to this group, and that is that we looked at the outcomes, the mortality outcomes of people who were committed to psychiatric services. So they were folks who have some psychiatric challenge that permitted them to actually, and they were at risk for them to themselves, somebody else, or to imminent grave disability or death. Those folks, we have about 5,000 a year people have that condition in Allegheny County, which is Pittsburgh. So about 1.2 million people. When we look at the mortality statistics for that population over a 5-year period, what we find is that 20% of them are dead. Mm. And some of it is psychiatric, of course, there's suicide. Some of it is overdose, and some of it is medical. And the challenges that this high morbidity mortality group carry, I think just reflects the need and the issues that the challenges that we're facing here in the United States and elsewhere. So I'll stop there.
No, thanks, Ken. And Richard?
Nothing to add other than my comment.
Yeah, there's certainly some challenges, and I think internationally we're sort of very conscious of the uniqueness of US in terms of gun deaths and gun violence. It's yeah, that's an incredible hard nut to crack. And Ken, I think your recent data, echoes, what's been quite frankly known around the world, but it really highlights it and brings it up to sharp relief in terms of the premature mortality of people with serious mental illness. Some of our recent research, we found even people with moderate depression and anxiety are actually at risk of 11 years premature reduced life expectancy as well. So it's not only people with serious mental illness and severe mental illness, it's actually a lot of people with the experience of mental health condition with their contact with primary care services. Yes. So in Australia, there's a number of things going on. We're very pleased to say we've got our next tranche of funding from the Australian government. So we have a different model where a small backbone team of, I think, roughly probably about 3 or 4 people full-time, but 7 bodies, and part-time sort of work on a collective impact approach. And we work with committed partners through a national consensus statement and also imperatives in the Australian National Mental Health Plan, a little bit like the Sharing the Vision plan in Ireland. So that's our authorising environment, as well as recommendations from our Productivity Commission. And so we work with a lot of partners, which includes all the governments, all the provincial and national governments of Australia, and all of the colleges, most of the NGOs, etc., have all committed to that. And we work through those as a very small group based in a university. And I think Shazana, I think it was you, or maybe Kiara, saying there's a real positive attitude, and that's true. People who work in mental health and primary care, they get holistic health. So we talk about, I think we're allowed to say it again, but the coalition of the willing. People get this, and there's very little resistance in principle. Often it's practical issues that makes it hard to change practice. Just a couple of other things in our funding. New funding envelope, we've got some funding to run a framework for consumer and a toolkit for consumer advocacy. And so at our recent conference in May, we did comment that 13 years ago, Professor Sue Bailey from Rethink, the Rethink report, said that this is a national shame. It's a scandal, but no one talks about it. 13 years down the track, it's pretty much the same in terms of government policy in Australia, at least. We are getting some traction, but not nearly as much as, we don't talk about this as much as gun violence or domestic violence, yet we're talking in Australia 46 preventable deaths per day. Preventable, excess, not total, preventable deaths per day in a population of 25 million. So I think if you extrapolate this to your populations, which are mostly much bigger, that's a lot of potentially preventable deaths using the OEC definitions of that. So we've got some funding to take it to actually try and train people with lived experience and their supporters to be advocates, political advocates, to get it on the much higher up on the funding agenda. As I mentioned, we've just part of that is the national report that we've done, a national data linkage of every Australian and the physical health outcomes. So we've just published that. And our next step on that one is to publish start to track our progress. And we've got funding to do that again. So we'll be able to track the life expectancy gap over the last 15 years using the entire database of everyone who's used the health service and everyone who's been in the census, which is really about 98% of the total population in Australia. Also just flag that we've got Lee, I'm not too sure. Simon Kozak presented at our conference and was just absolutely brilliant. We're so envious. We wish we had someone like Simon Kozak here in Australia. We're casting our minds to have such great advocates. But Lee, I don't know if those videos are available on our website yet.
Yes, and I put Simon's presentation, the link to it, in the chat.
Yeah, just a brilliant presenter. He needs a job in public relations. So, and it's so great to have the passion of someone who provides this work pro bono. I think that's a whole other way of, getting into this sector. Also have an ad for our next conference, which is slated, I think, for November in Adelaide in Australia. And if anyone's planning a trip to Australia, we're not allowed to pay international fees, but if you can get yourself to Australia, we're very happy to get you to Adelaide, which has been voted the world's most beautiful city by the International Architects Association, and put you up there, and we'd love to have you present an international thing. So anyone who's looking at a trip to Australia, October, November is a gorgeous time to come. It's at the end of spring in our place.
Can Harry come?
Oh yeah. Well, no. Australia is very strict about their biosecurity, and we'll have to spend 6 months in quarantine before we let him out, and probably $20,000 in vet fees. So he's welcome. You didn't hear about Johnny? Is it Johnny
Depp?
Boo, our Minister for Agriculture, I think, threatened to shoot the dog. And Johnny Depp, it's really funny. He had to do a public apology for trying to bring his dog in on his private jet. So it was quite a controversy over here, and everyone thought it was quite funny. Sort of a right-wing farmer type of politician versus Johnny Depp. It was an interesting exchange. So yes, he'd be welcome, but just make sure you do things properly.
All right, he can stay here.
A couple of things, other things for us. Someone was talking about the micro learnings. I think Emma, and yes, we're partnering with MH Pod, which is Mental Health Professional Online Development, which is funded for the Australian government, and we're going to put out a series of micro learnings around physical health and mental illness. That's available internationally. That's not firewalled at all, and it's funded by the Australian government for anyone who works in mental health in Australia. And so we might even tap a few people on the shoulder for a bit of an international, credibility and for those micro learnings. I think we're going to start off with the screening generally, the importance, and also cancer risk and what we should do around that. And I think we've got 2 of those which are due by the end of the year, and then probably another 8 that we're going to look to have next year. So when they're available, we'll share them, widely as much as we can. And I think for us, our emphasis in the next tranche of funding is, I think we've done quite well in terms of influencing authorising environment with guidelines. I talked about people with guidelines. Every jurisdiction has those practice guidelines, so clinicians mandates, but our emphasis, I think, is on the national influence in the national immunisation program. In Australia, more people die of influenza than suicide. More people with mental illness die of influenza than of suicide, and suicide is a hard nut to crack, but influenza, it's a $20 vaccine. And so one of our jurisdictions that has actually funded vaccination program for people with mental illness, but we're hoping to try and make that national, and we'll share some of that data which says influenza related deaths, 3 times the number of deaths 5 times the number of hospitalizations and 7 times the number of hospital bed days. A bed day is $2,000 a day in Australia. A vaccine is $20 once a year. So we think that's the case, and we're going to work with our College of Psychiatrists to do a return on investment analysis on some of these interventions to once again try and get the policymakers to do some stuff there. So we continue to work with the governments and the public mental health and NGO services, which are really doing fantastic stuff. They're really just doing some great work. And Lee, if you could share our Equally Well in Action, we try and scan the implementation activity as a measure of progress, because as you know, this is a long pipeline, influencing cardiovascular disease or cerebrovascular disease. That's a generation, that's 10, 20, 30 years in the making, Ken. But you've got to start somewhere. So we're starting to, measure, track that progress. But the states are really doing some awesome stuff there. And so now we're looking in the next tranche to get into mainstream health and with the cancer, because, more people in Australia, the 20% of people who access mental health services comprise almost 60% of total cancer deaths in Australia. So the 20% make, 60% of all deaths, and the 80% have fewer deaths. So we're trying to get that health equity. This is despite the fact that the incidence of cancer is the same or lower. So there's some of the things that I think we've got happening in Oz. Lee or Vic, anything else that I've missed? No?
All good.
Okay. Now we've got to buzz through. We're now on to point 4 of our agenda. So Vic, I think I've asked you to talk quickly about, we've only got 20 minutes left, so quickly about the Equally Well match, and then we'll talk about the Global Leadership Exchange updates. If you could give a quick report back on that match. And I think you have the Padlet from the match. Thank you, Susanna and Vic, for putting that together, which is a bit of a report of the match. But Vic, I'll hand over to you.
Yeah, briefly, thanks, Russell. This is my first GLE match, so I'm the comms lead with Equally Well Australia. So I'm really all about how to make these connections work better. So this forum is a really great way to listen in on how communication's helping all of us do the work that we want to do in this space, and the communities that we support. So firstly, huge shout out to Shazana, Hannah, and the whole Equally Well UK team for hosting the GLE match in London on the Right to Life, which included Equally Well representation from a couple of fabulous faces here, Thomas, and we've lost Manisha. Yes, I think that's it. And then Hannah and Shazana. And it also gave us an opportunity to explore some extended perspectives from people with from disability groups also who attended, a couple from Australia, which was wonderful. So it opened up this whole discussion of what are the factors that impact the success of this movement to health equity, and what are some of the challenges and barriers that we're facing. And what we're hearing in this group is sort of echoed in the snapshot of participants in London, in a sense that everyone's on different levels in their journey. And some of the key, I guess, takeaways from that little GLE intense group before some of us had the good fortune to be able to head to Utrecht, was that we really want to expand that network to really ensure that the representation for those kind of opportunities also are shared equally amongst people with lived experience. And we were so thrilled to have Hannah with us, and hopefully we'll be able to expand that capacity in the future. So that was one big takeaway from that group, that all perspectives count, but it's really important that that sort of is really strengthened, that we want to develop really good communities of practice around specific areas. So obviously my focus is communication. We had some wonderful presentations from Joe Firth and Helen and others internationally. So it's kind of the opportunity to connect with those people that you have a synergy with, and try and do what you can to shine a light and expand the capacity of your area, whatever that is. So that was something that came out of that. Lots of lovely connections. We want to build on this collaborative learning network, so that's fantastic, and look at how we can build on where we might want to go in 2 years' time. So what is this group? What could we do? And I think throwing to that, Russell, we have the scorecard as one example. We also have discussions about the public value of the work that we're doing and how to evaluate that. So evaluation, monitoring success, what does that look like? There's so many ways those conversations could have gone, but we had some lovely intense workshops, and then we came back together and really sort of blew out the ideas. And the Padlet, which was attached to the meeting invite, was a good snapshot. Catherine, I apologise. Obviously you were there from Australia, and Russell. I was kind of more leading out to our international partners who did such a wonderful job in hosting us. So yeah, I'll leave it there. There's lots more to discuss, and yeah, it'd be great to see where this takes us in 2 years' time. Perhaps it'll be an equally well-focused event or something more. We'll see. We'll see. Watch this space.
Thanks, Vic. Kath or Susanna, did you have anything more to add, or Thomas around the match, or Hannah? So I'm just casting my eyes across the.
No, I think Vic covered that really well, really thoroughly. So yeah, just reiterate the same points. I don't think I've got really anything to add.
I think I did call out to Steve, and someone here might know more than I only suspect, whether or not the GLE is having their sort of, I don't know, regional meetings next year in 2025. You know, last year they had one in, I think, in Europe, one in South Pacific, and one in the Americas. Does anyone know the plan for the GLE 2025? No. No, I haven't heard back. So, no. But that has been their trend over the last years before COVID, that they'd have an international meeting once every 2 years, and then a regional meeting in the intervening years. So we'll just keep a track on that. But certainly, you know, encourage you to put somewhere in Canada. I think it's north of Vancouver. I think Christopher has got in mind. For our Equally Well match in 2026. So really looking forward to that. And just leading on from that, some of the actions, steps going forward. And Vic, I don't know if I get you to be able to just share the steps going forward slide that Shazana produced, but my recollection is there one is for this group to reinvigorate. So thank you for coming in. It's such a great meeting to hear all the things that are happening. We've got so much to learn from one another internationally, but also an opportunity to start to advocate nationally using international experience. And I think particularly for you, Manaza, you know, to see what's happening around the world, because we're all on the journey, but we're all on different stages of the journey. And some are sort of beginning, and some are sort of revising, and some are even in almost in the, I won't say pre-contemplation stage, but in the contemplation stage. So I think we can all, you know, learn from one another in that respect. The other action, and one of the things about keeping groups like this together, is to actually have a shared activity. I thank Shazana. Where to from here? Continue to meet. That's good. Build international. Yes, good. Community to practice on communication. That would be you, Vic. Lived experience international collaborative opportunities. And that is something we did notice, that a lot of governments, a lot of people like myself are funded by universities to travel internationally for conferences, but people with a lived experience and experts by experience often don't have that support and funding. So it means that voice is not present to the extent it should be at these things. So I think this is something we really need to address, because it is another level of inequality and discrimination, really, and that you know, systemic discrimination for people with experts by experience. So we really need to try and address that. And any ideas on that would be great. Research methods, and then GLE exchange. And so I'll just segue into the physical and mental health scorecard. This is something that we were looking to do together. You've got some attachments there. And we're hoping to beta test that. And thank you for our friends in New Zealand for running a version of that. I think that might have been you, Emma, who did an earlier version of the scorecard. And we're looking to also try that in the UK. And once we beta test that, we're then looking to do this more internationally so that we can actually report back to what extent is the physical health of people living with mental illness present in the policy environment. And if you have a look at the scorecard, it goes in quite detail, like, are there practice guidelines? Is it present in suicide prevention? Is it present in chronic disease framework or promotion prevention? Is it present in the National Mental Health Plan like it is in the Sharing the Vision in Ireland, for example? So that's a big tick. Is there an implementation committee? Another big tick for Ireland. Is there funding dedicated to the implementation? Another big tick for Ireland. So I think where Ireland is going, it'd be all in the green side of this. We sort of have combined a stoplight system with a fuel gauge system. So red is like nothing's happening. The grey is it's in the middle, and then green is like it's going great. And so it's a dial that goes across a fuel gauge. So you sort of get a point. And what we're wanting to do is sort of internationally sort of have a bit of a scope of where this is at. And that will be helpful in a number of respects, we hope. One, in us trying to understand where the gaps are in each of the different countries. Two, to identify which countries are actually leading in certain areas, such in chronic disease prevention or mental health policy or suicide prevention policy. And three, to highlight in our various countries to say, look, and Ireland and UK and New Zealand are doing great here. Why isn't Australia, up to speed here? So a little bit of healthy international collaboration, and the same in Canada as well. So we can all use this as a really to benchmark where countries are and really try and benchmark best practice in this. So we're looking to finalise that. And we have some support and capacity here to drive that. So the plan is that we, once, I think in the next week or so, we should hopefully have got some of the bugs out of this program, and it should be run pretty smoothly. We'd then send it to people in different countries to start to fill it in, and we can help with that. And then, and also to send us through any of the policy documents or guidelines that you're aware of. And then our research assistant in Australia will also do it. And then we'd be looking at publishing this in terms of, World Psychiatry or a publication like that to say, well, where are countries up to with this? So that's the next step. So we're really looking for connections in each country to say, to connect us to that. And we've got capacity to help you with it. And we can even do all of the analysis ourselves, and it will just be downloading it onto NVivo and doing a search for keywords. Shizana.
Sorry, yeah, I had a go at doing it this week, and to what extent, because we talk about different policies and different strategies and different guidelines. To what extent are we talking about across national kind of policy, or where there's strong evidence within a certain guideline or a certain guidance, like we're doing a lot on physical health checks, for example, but also that's it. So whereas within that area it's quite high, whereas across the board or across the whole system it's not. So it's a bit, so I was just trying to, and I've highlighted that, but it's just kind of to what extent, how do we cover
I think
it?
that's exactly the sort of issues that we're looking to sort of address, that the UK doesn't have a national mental health policy at the moment. And a lot of people are commenting that that's a gap compared to other countries that do have an overarching approach to this. So that might be one of the asterisks and a bit of a comment on, there'll be a gap there completely, which will highlight, hopefully, with the new government, that the need for an overarching direction for mental health, like the Sharing the Vision one in Ireland. So that's exactly the sorts of things we're wanting to sort of try and unpack, and that's some of the nuances and the detail that we'll only get when you actually jump into it. Also, if there's any other conferences, I do understand that the College of Psychiatry conference next year in the UK in Wales is looking to highlight physical health and mental illness and have some sessions on there, thanks to Peter Byrne from the NHS. So that's great news. But if you're aware of any other conferences where the physical health and people with mental illness is coming up, please share that, and we'll certainly share. Ken was having a go at Pittsburgh. Pittsburgh's a pretty nice. I agree, Pittsburgh is a very beautiful architectural city, but I'm not going to.
But you're completely biased, so let's just leave it there.
No, I'm not going to argue with the International Architects Association. So if they say Adelaide's the best, Adelaide is the best. So we'll give you the details of our conference next year as well. Any other items? We've got 5 minutes. Any other business?
Just to add to that, so we're putting a proposal in to present at the Congress next year in Wales as well. So maybe it's worth them speaking to Peter and having a chat.
Yeah, absolutely. Yeah. No, that would be fantastic.
Yeah, physical health checks and SMI on the map there.
Yeah, that's brilliant, Susanna. And hopefully, Paul, I saw you make a note, so hopefully someone from Ireland will sort of come across and be able to be at that meeting too. Maybe you and Phil and John.
We'll do our best. Absolutely. Yeah, sounds very interesting.
It'd be great to see you guys again in person. Any other business?
I mean, before we finish, can I just share, I think it was quite a nice little story. It's not long. So recently, Tipo, we were at one of the GP conferences here in New Zealand. So it was about all of Tipo's work, but we of course had our Equally Well sort of banner on display. And this GP came up to me and sort of said, Equally Well, the phrase is really good. And I wasn't quite sure where this was going to go, whether he knew anything about Equally Well or not. Because anyway, what transpired, he told me the story about how the phrase Equally Well is really quite a powerful phrase for him, because he keeps it in his mind whenever he is seeing anybody in his practice that has addiction or mental health issues. Equally Well is like that little earworm to him, to remind him to ask some additional questions. So he says, like often I'll get caught in terms of just remembering to think about all the things about their mental health issues. But when I think of Equally Well, I think, okay, I need to ask them this, I need to ask them this, and I need to ask them this. So it's really changed the way in which I am and the questions that I ask or the things I think about, purely down to the words of Equally Well. And I thought, I would have never have thought that a name of something could actually change, the way in which someone is in their GP practice on a day-to-day basis. So I thought that was a really nice, positive little story, and it made us reflect on how the whole terminology of Equally Well came about. And so I just thought that might be a nice thing to share with people, that, completely unprompted and never expected that on my day that day.
It's lovely when something like that happens. And Emma, thank you for that reminder. Equally Well is not proprietary, it's not a commercial thing. So if any other country wants to use that term for their initiative, you'd be most welcome. In fact, we'd be delighted. So I'd only just suggest that you jump in and claim the domain name before someone else does, a gymnasium or something like that. So all UK, Australia, New Zealand all use the term Equally Well, but it's all, it's not trademarked or anything internationally. So and we quite like the fact in terms of an international movement, because it's right, that really does capture a lot in those two words. So in Ireland and Canada and Belgium, if you want to use that we'd be delighted, but you're not obliged, of course. No, thanks, Emma, for that reminder. Any other? Well, listen, thank you, everyone, particularly those who are getting towards the end of the day, for your endurance. I know some haven't endured quite well. Tomas, you get the gold medal. You're still here, and you're the latest of anyone in the world. So congratulations, gold star to you. Our next meeting, I expect, where are we, September? I think it's probably going to be early next year, probably in February. Like I said, we look to have them 3 or 4 times a year. And for us, I know in the Northern Hemisphere, you have a big break around July, August. We have our big break around December, January in the Southern Hemisphere, you know, our summer holidays. So I think we'll probably make it around about February. If there's any items for the agenda, please just send me or Lee a link. And I will also point out that Lee Cobb, the wonderful, amazing Lee Cobb, is going on 6 weeks holidays as of tomorrow. But if you email her, someone's keeping an eye on that, and Sky's sort of filling in, doing the admin. She can't replace Lee, but she can just keep coverage for a while. So just publicly thank Lee for organising this meeting and taking the minutes. And before you go on holidays, Lee, we need to get some notes and the recording it out. But if you've got any suggestions in the meantime, just let us know. So thanks everyone. It's 7:30 and it's just been a wonderful meeting, and I really appreciate the input from everybody. It's been fantastic.
Thanks, Russell, to you as well.
Thanks, everyone.
Thanks, everybody.
Have a great day.
Good to see
Evening.
you. Bye.
Everyone.
Kia ora. Take care. Thank you.
Yes, Emma.
Where do I leave?